All right, this is the MS2 ankle palpation video. So initially we have the medial malleolus on the inside. On the outside we have the lateral malleolus. We follow down, we have our fifth metatarsal on the lateral side. On the inside we have our most prominent bone, which is the navicular. Then for our posterior tib tendon, it runs behind the medial malleolus and then runs down towards the navicular. For our peroneal tendon, it runs behind the lateral malleolus going around the cuboid, so we're following it down this direction. Next is our anterior tib tendon. To make this more prominent, I will have the patient push up into my hand. So it is right here. This one that's crossing the joint. And then next we have our medial plantar calcaneus tubercle. So for this, I'm going to have the patient, I'm going to apply pressure to the patient's great toe, and then I will track down the plantar fascia until I reach the tubercle on the calcaneus. Next is the Achilles insertion. So we're palpating down, so it's the Achilles tendon going down until we reach its insertion point on the calcaneus. For our lateral ligament complex, we have the ATFL, which is anterior to the lateral malleolus. So it's kind of in this divot right here. Directly inferior to the lateral malleolus is the CFL. So we're running sideways against it since it's running vertical, so we will run lateral to it. Lastly, we have the PTFL, which is posterior to the lateral malleolus. Now for our active range of motion, we will use our goniometer. So the stationary arm is going up to the fibular head. The fulcrum is at the lateral malleolus, and then the movement arm is at the fifth met. We are then going to ask our patient to dorsiflex their foot up. Let me take it. Alrighty. So normal for the ankle is 20 degrees of dorsiflexion. She was, here we'll have you do that again. She's right at 20. And then can you plantar flex for me? So here she has a little bit of excessive mobility. She's at 80 degrees and normal is 50 degrees. We then will also do great toe, plantar, and dorsiflexion. So the fulcrum is at the met head. We're then bisecting the first met, and then the movement arm is at the proximal phalanx. So we are at 80 degrees of dorsiflexion. Normal is between 70 and 90, and then plantar flexion, point down. Normal is at 45 degrees, and she has roughly 15, but I may be measuring that one incorrectly. Next is plantar or passive range of motion. So for the ankle, we are going to dorsiflex the foot. So we should have a tight end feel based upon the calcaneus tightening up, or based upon the Achilles tendon. And then if we plantar flex, she's a little bit more laxity when we do some plantar flexion, but still getting that tight end feel. Next, for joint mobility, we're going to do a post, oh, I forgot, we also have to do the big toe passive range of motion. So we're just stabilizing at the met head, and coming down, and coming back. Next, posterior talus glide. So we're stabilizing at the proximal tib fib, or distal tib fib, and then applying an inferior force below the talocrural joint, assessing for hypo, hyper, or normal mobility. She has normal. For rear foot assessment, I would ask the patient to lay on their side. If I'm assessing medial mobility, I will then be using the patient's leg that's on top, and I will be applying a force downward while also stabilizing at their distal tib fib. And if I were to do a lateral mobility assessment, I would also stabilize the tib fib still, but then I'm pushing out while still pushing inferiorly. But for this video, I want to be able to show both at one time. For midfoot mobility assessment, can you lay back on your back for me? For this one, we are stabilizing the calcaneus, and then we are just moving the foot into eversion or inversion, and then eversion. For first MET, what we're doing is we're stabilizing MET heads 2 through 3, and then we're just moving the first MET. And then for the MTP joint, we are stabilizing the first MTP head, and then we're moving the phalanx posterior and then anterior. And then we're assessing for hyper, hypo, or normal. They're normal. And I would do the same on the other side. Lastly, I will have the patient come to the edge of the bed, and we'll do manual muscle testing. So first, for dorsiflexion, I will have the patient press up into my hand. So it's dorsiflexion. Press down like you're going into a gas pedal. Good. For eversion, I will have them press out into my hand. Good. And then for inversion, I'll have them press into my hand. Good.